Hello everybody. Today we are going to discuss about the polytrauma. Polytrauma remains the global health concern and has been identified as a key issue in the future health care by the WHO. Despite advances in the diagnosis and treatment algorithm, trauma remains the leading cause of mortality and the disability worldwide. It is a prominent cause of mortality in the young adult due to increased road traffic accident. However, with the changing demographics and the older population, elderly patients involved in the polytrauma are increasingly being seen. The healthcare costs spent in the acute and emergency setting are statistically proven to be significant higher in the polytrauma. The precise definition of the polytrauma has been refined over the last few decades due to recognition of the clinical pattern, organ system involvement, and the associated physiological changes. The Border et al. In 1975 introduced the first formal definition of polytrauma, where polytrauma patient was defined as having two or more significant injuries. However, for considerable period, definition of the polytrauma were based on injury severity score with its modification. So abbreviated injury score which specifies the involvement of more than one injury severity score body region gain recognition to enhance the definition of the patient with the polytrauma. So polytrauma was acknowledged as an injury with the abbreviated injury score of more than 2 in at least two ISS body region. Following a call for universally accepted definition of polytrauma, an international consensus process to develop database supported definition of polytrauma has been developed. So, as per New Berlin definition, polytrauma is defined as patients with abbreviated injury scale of more than 3 for two or more different body regions, with one or more additional features from the five physiological parameters of age, consciousness, hypotension, coagulopathy, and acidosis. So abbreviated injury scale includes score 1 is minor injury, score 2 is moderate injury, score 3 is the serious injury, score 4 severe injury, score 5 is the critical injury, score 6 is the virtually unsurvivable injury. So management of the polytrauma patient begins at trauma site and should always follow continuum of the care through pre-hospital phase, accidental emergency unit, and necessary damage control surgical intervention. The timing of interventions and surgery in the management have evolved due to better understanding of clinical, physiopathological, and the immunological response in trauma. This has led to the paradigm shift in the delivering trauma care from early total care, damage control orthopedic to the current philosophy of early appreciative care and prompt individualized safe management. The goal of trauma team are to register the patient's problem, institute priorities to save life by using advanced trauma life support protocol and stabilize the patient before transferring the patient for specialized care. Multimodality approach in the managing polytrauma have been proven to reduce the mortality rate significantly, and however, there are various risks involved in each stage of polytrauma patient care. This discussion provides an insight into management of polytrauma patient from the team approach perspective, with the focus on the risk involved at each stage, provides early recognition and suggests effective treatment of this to improve patient-related outcome. So polytrauma management stages and the risk associated with each stage in the management of patient with the polytrauma. Stages representing polytrauma care include pre-hospital care, accident and the emergency department resuscitation and management, model of polytrauma care, damage control, orthopedic and definitive fracture fixation, and then rehabilitative phase. Now, the pre-hospital care. Pre-hospital care has evolved significantly with the period of military conflicts. The advent of ATLS in 1978 was shortly followed by pre-hospital trauma life support in 1984, aimed at training pre-hospital provider in systematic approach to the injured patient. Pre-hospital care has dramatically changed the outcome of polytrauma patient globally with utilization of the pre-hospital trauma life support. Pre-hospital trauma life support is the standardized algorithm aimed at improving the outcome of trauma patient by focusing on improved prioritizing medical demand in the patient. A proposed as proposed in the trimodal distribution of the death following polytrauma by Baker et al. The first peak occurs at the scene of injury, and hence patients should receive definitive care to decrease the morbidity and mortality. So the pre-hospital care has been evolving since its formulation, and it includes stepwise assessment of the patient for administration of vasoactive medication. Tubin et al. In 2019 composed the efficacy of pre-hospital care with following endpoints, that is percentage of the emergency doctor involvement, total operation time, and transfer time. All three components have shown increased efficacy with the use of pre-hospital trauma life support. The pre-hospital environment presents the several challenges that could range from hostile patient to the hostile environment. So pre-hospital care is based on the ATLS principles. Pre-hospital infusion in the polytrauma patient. Management of the hypovolemic shock should be started after securing intravenous line to decrease the hospital mortality in trauma patient. This intravenous line administration has been a key component of pre-hospital management of trauma patient since the advent of emergency medical services. It is intended to hemodynamically stabilize trauma patient by replacing intravenous volume and maintaining vital organ perfusion. However, there has been increasing evidence that IV fluid administration would cause more harm than good and hence to be discouraged. Few theories supporting the statement includes the delay in the rapid transportation to the definitive care, and the other main reason being rise in the systolic pressure upon administration of IV fluid, resulting in hypertension and vasodilation affecting tamponade effect and further bleeding. In patients with traumatic brain injury, the focus should be to prevent development of secondary brain injury, and hence IV fluid administration has to be used cautiously. In summary, pre-hospital IV fluid administration is to be restricted to penetrating injury, severe head injury, and patients requiring emergency surgery. So the routine use of IV placement and fluid administration for all trauma patients should be discouraged. Now, the pre-hospital hemorrhage control. The control of external bleeding, patient immobilization, and the rapid transport to the nearest facility should be done at this stage. Hemorrhage is the leading cause of preventable death in combat trauma and the secondary cause of death in the civilian trauma. External hemorrhage is one of the preventable cause of death in the polytrauma patient, with evidence-based guideline published in the literature. So hemorrhage can be controlled with a direct pressure or the pressure bandage. If direct pressure fails to control bleeding, a tourniquet with or without hemostatic substance can be used to stop the bleeding. Extensive researches and the trial are in place globally in assessing the effectiveness of hemostatic agents, surgical agents, and the blood product for hemostatic resuscitation in pre-hospital setting. The hemostatic agents are broadly classified as systemic agent and local application agent. It has been shown that tranexamic acid can improve the survival in severely ill patients if given within the 3 hours of injury. Local hemostatic agent, though, may decrease the time to the treatment and adverse effect, but not very effective in case of severe bleeding. Klein et al. On their research into emerging therapy for pre-hospital hemorrhage control elaborated and non-scale injectable therapies and the synthoplates. However, further human trial with these products are in need for them to effectively made use in both combat and the civilian trauma. Now about accident and the emergency department resuscitation and management. Adequate resuscitation remains one of the key aspects in decreasing acute death in polytrauma patients. Airway breathing circulation disability and exposure assessment algorithm advocated by advanced trauma life support, increasing efficiency and quality of care in polytrauma patient in accident and emergency department. The priority remains identification and stabilization of potentially life-threatening injury. ATLS-based systemic approach allow the rapid assessment and the management of any compromise in airway, breathing, circulation, and neurosurgical insight. The aim is to prevent development of lethal triad of coagulopathy, hypothermia, and acidosis. So the modern trauma management is based on good teamwork and leadership. In UK trauma practice, the emergency medicine doctor tend to lead to the trauma team. When there is a history of significant mechanism of injury suggestive of or significant trauma causing airway injury, it is important to get anesthetist to join trauma team at this crucial stage. So following Professor Richard Scovel's observation, Second World War, initial 60 minutes following trauma is described as the golden hour. So golden hour is the period of the time when life-threatening injuries should be treated in order of severity to decrease the mortality. An estimated 60% of avoidable death can occur during this period. And optimal care of the trauma victim is crucial for the good outcome. The trimodal peak distribution of the death after polytrauma and suggested intervention to mitigate this risk. So this is the figure illustrates the trimodal peak distribution. So the first few minutes is immediate, non-survivable fatal injury, injury preventable surgery. Then second is the golden hour, that is early preventable death, improved access to the pre-hospital and emergency room, trauma service, and the major trauma protocol. Then in after first week, there is late death due to multi-organ sepsis, failure, ARDS, improved. Then how to tackle this? We need to improve resuscitation, timing of surgical treatment, and physiological monitoring is necessary. So first is airway control. Airway assessment and the management remains the priority in the ATLS algorithm during polytrauma resuscitation. Any trauma victim is considered to have difficult airway unless mechanism of injury does not suggest cervical spine trauma. Careful consideration of cervical spine injury should dictate the airway interventions required, which in most cases will require cervical spine stabilization with cervical collar. During advanced airway management, the cervical collar must be removed and replaced with inline immobilization provided by suitable trained team member. The management of the airway can be complicated by facial injuries, the fractures to the mandible and the maxilla, bleeding, burns to the face, upper airway, dislodgement of the teeth and the denture, and injury to the upper airway. This can be complicated by the presence of gunshot or the open bleeding injuries of the neck or presence of undetected pneumothorax, which can become worse after endotracheal intubation. Hence, the biggest life-threatening injury in the airway is airway obstruction causing hypoxia. Careful management of the airway with oxygenation and airway adjunct or definitive airway intervention is indicated in patients with facial burn involving upper airway and presence of unstable facial bone fracture or laryngeal injury, which have potential to cause total airway obstruction. Maintaining definitive airway is one of the key steps in the reducing mortality rate in polytrauma and restricting the progress of inflammatory casting. Although there is a debate that no significant association between successful definitive airway and pre-hospital setting and survival, but it is one of the key parameters in improving survival rate in the hospital setting. The availability of the adequate equipment and the trained personnel in the emergency department are two important factors aiding the success rate of the securing definitive airway, as it could be the quite challenging in the pre-hospital setting. Securing an airway is the crucial for survival of complex trauma patient, especially in patient with traumatic brain injury and burn patient. Definitive airway intervention might include option of needle and surgical cricothyrotomy, tracheostomy, endotracheal intubation. Rapid sequence intubation is the technique that practiced globally in the emergency setting. It has to be emphasized that securing definitive airway in an emergency setting is one of the critical factors predicting the survival of polytrauma patient. In addition to the traumatic injury, the patient may present with the full stomach on the board due to lack of adequate starvation period and the prolonged gastric emptying time in the trauma. So standard practice is to treat them as a full stomach and the perform rapid sequence intubation with required pressure application by suitable trained operative department practitioner or an anesthetic nurse or emergency medicine nurse specifically trained for providing this. Now about breathing and ventilation. Chest injuries can complicate anesthetic management of the trauma patient. The extent of the chest injuries depend on the mechanism of injury, speed of the vehicle involved in the crash, the impact, or there is entrapment of the victim in the vehicle. The following are life-threatening injuries, that is tension pneumothorax, untreated open pneumothorax, massive pneumothorax, cardiac tamponade, and the tracheobronchial injury. Positive pressure ventilation using endotracheal tube in patient with undetected pneumothorax can lead to life-threatening tension pneumothorax. Any pneumothorax should be carefully considered and if in doubt need to be dealt with emergency need thoracocentesis followed by urgent chest strength insertion. This can happen in patients with simple pneumothorax, untreated open pneumothorax, or undetected small tension pneumothorax. Persistent pneumothorax with bubbling of air synchronizing with the positive pressure ventilation indicates major tracheobronchial injury that will require emergency advanced management of airway, including one lung ventilation and transfer to center capable of performing cardiothoracic surgery. In the absence of life-threatening injuries, this patient might present with a high-impact chest injury. The signs and symptoms of all thoracic injury may not be the obvious due to concomitant presence of significant hypovolemia due to blood loss. Simultaneous radiological investigation should be carried out while resuscitation is in process. Now, circulation and hemorrhage control. Hemorrhage is one of the most common risks in the management of polytrauma patients. So, rapid identification of site of hemorrhage is crucial in reducing mortality in polytrauma patients. Definitive control of hemorrhage should be the goal with rapid replacement of blood volume. Damage control resuscitation should be initiated efficiently. An incorrect damage control resuscitation has the potential to exacerbate lethal triad of acidosis, coagulopathy, and homeostatic imbalance. So, initiative taking steps such as external direct compression and judicial use of tourniquet to stop the bleeding distally in the limb can be undertaken. Source of bleeding should be considered carefully by looking for confined spaces and external bleeding. The source of external bleeding can be as simple as extensive blood loss due to scalp laceration or cutaneous bleeding in the head or neck region. Massive hemothorax can produce bleeding up to or above 1.5 liter, which can easily be missed by clinical examination due to lack of percussion over mid-axillary area. Focus assessment of sonography for trauma scan can help in detecting blood around the liver or spleen or in the abdomen pockets or in the pelvis. So the early application of pelvic binder in trauma patient are key to minimize the blood loss. Significant amount of the blood loss can occur due to long bone fracture. The application of appropriate splint to reduce the fracture will help in reducing pain as well as excessive bleeding. The importance has to be given to seeking information about blood loss at the scene from the paramedics. Assessment of circulation and the restoration of intravascular volume with balanced resuscitation should be supported by early blood transfusion and administration of hemostatic agent like tranexamic acid. Other exogenous methods have been used to control bleeding, such as antifibrinolytic agent like tranexamic acid, junctional emergency treatment tool, compact ready cam, SQ form, resuscitation endovascular balloon occlusion of aorta, and invasive technique of aortic occlusion has been reported to be safe and effective in patients with traumatic hemorrhage and hemodynamic instability. The definitive treatment of hypovolemia should be considered simultaneously. In addition, massive bleeding patient may present with the DIC resulting in significant coagulation disorder requiring blood and its component for resuscitation. The presence of muffled heart sound in patient with the distended neck vein is an indication of cardiac tamponade which require urgent treatment. These patients tend to have significant anterior chest wall impact injury with multiple fracture, flail chest, and the contusion of underlying lung predisposing to ARDS. Now about disability, and patient with the trauma can present with the reduced level of consciousness, which complicates the assessment of the patient. Reduced level of consciousness can be due to head injury, which should always be considered as an first cause, even when evidence of excessive alcohol intake is obvious. Patient with a reduced GCS will always be considered to have cervical spine injury, and neck is the triple immobilized using cervical collar, block, and tape. Airway intervention may need to be considered in patient with reduced GCS. When patient presents with multiple life-threatening injuries, careful team discussion should follow appropriate clinical decision making and prioritizing the immediate life-threatening problem with consideration given to simultaneous managing multiple life-threatening injuries. Now about exposure and environment, depending on the severity of injury, the time taken for the excretion of the patient from the motor vehicle or recovering from the debris can expose the patient to very low temperature, causing significant hypothermia and crush injury. Early warming and careful management of crush injury is paramount in the managing this patient. One of the biggest risks of traumatic injury is the loss of skin and exposure of infected material and debris associated with the injury. Early strategic management of the trauma victim can prevent the death. However, catastrophic delayed outcome can be prevented by combining the best care in the initial stages with careful crucial management to prevent wound contamination and bacterial infection leading to sepsis. Otherwise, most trauma victims can suffer significant morbidity and mortality due to sepsis. Now, the managing specific risk due to during polytrauma management. That is the lethal triad of coagulopathy, hypothermia, and acidosis. So the events in the polytrauma is first there is first hit phenomenon, which results into the tissue damage, hemorrhage, hypoperfusion. That leads to hemorrhage leads into the shock. Then there are some trauma related factor like acute coagulopathy of shock and the blood loss. Then there are resuscitation related factors are contributing, which results into the hemodilution, hypothermia, base acidosis, and hypocalcemia. Hemodilution is occurring when we are administering excessive fluids. Then hypothermia, base acidosis, and hypocalcemia may result from the transfusion of the blood. That might lead to the lethal morbidity, lethal triad of the mortality, which is hypothermia, coagulopathy, and metabolic acidosis. Then, in case of polytrauma with the high injury severity score, early major surgery and hemodynamic instability, second hit phenomenon is happening, which leads to the activation of immune system, SIRS, in a SIRS response, which leads to the infection, sepsis, multi-organ failure, and ARDS that results into the late death. Now, the trauma-associated coagulopathy. Trauma-associated coagulopathy in polytrauma patient could be due to the acute coagulopathy of trauma shock and resuscitation-associated coagulopathy. Undetected, it forms one of the component of lethal triad associated with mortality. Then, acute coagulopathy of trauma develops following injury before resuscitation measures are initiated. So the risk factor associated with the higher probability of developing coagulopathy include high injury severity score, pH below 7.1, hypothermia and hypotension below systolic blood pressure of 70 mmHg. Then activation of the protein C is the main proposed mechanism. So early detection of coagulopathy of trauma with standard bleeding profile, coagulation test, like platelet count, activated partial thromboplastin time, prothrombin time, INR, clotting cascade component, and point of care coagulometer may direct efforts towards targeted clotting factor replacement in these patients. Now, the resuscitated associated coagulopathy is the dilution of procoagulant factor following rapid infusion of crystalloid and colloid. Hypothermia, acidosis, and hypocalcemia exacerbate resuscitation-induced coagulopathy. Then DIC is the devastating complication of polytrauma. DIC is typified by the in vivo activation of coagulation system, resulting into the intravascular disposition of fibrin and consumption bleeding, leading to development of multi-organ dysfunction syndrome. Now about role of viscoelastic test. APTT, PT, and INR are traditional tests to diagnose coagulation abnormality. However, these tests only assess the initial phase of blood coagulation. Viscoelastic stage tests such as TAKE and the ROTEM, which can dynamically assess coagulation abnormality for effective correction and reverse, can be have been introduced. Coagulation profile and the VT are thus used to guide administration of the platelet, cryoprecipitate, fresh frozen plasma, and blood product. So the decision of transfusing platelet, cryoprecipitate, and the fresh frozen blood products should be depend upon the reports of our coagulation profile and the take. So damage control resuscitation involves rapid control of hemorrhage, prevention, correction of acidosis, correction of hypothermia, homeostatic resuscitation, and correction of hypokalemia. Intention of damage control resuscitation is to mitigate this resuscitation associated coagulopathy and correct existing coagulopathy. The balanced transfusion ratio of fresh frozen plasma, platelet, and RBC in the ratio of 1:1:1 is advocated with early administration of tranexamic acid to counteract possibility of resuscitation associated coagulopathy. Now, metabolic acidosis. It is one of the lethal triad of coagulopathy, hypothermia, and acidosis. Poor outcome has been observed if the base deficit exceeds 6 mmol per liter. Mild metabolic acidosis may develop due to early hypovolemic shock and the correctable with the volume resuscitation and monitoring. Severe metabolic acidosis occur due to prolonged severe hypovolemic shock and tissue hypoxia. Activation of anaerobic mechanism and formation of lactic acids are the underlying mechanism. Reversal of these mechanisms with the control of hemorrhage, fluid resuscitation, blood product will establish acid balance imbalance. Now about hypothermia. In patients with the polytrauma, the risk of hypothermia is substantial and can be fatal. Additionally, it can exacerbate coagulopathy and lead to development of dysrhythmia. Prevention is the best treatment for hypothermia with the close monitoring of the core body temperature. Hypotension and hypothermia should be managed with rapid control of hemorrhage, warm environment, external warming devices, warm intravenous fluid, and the blood transfusion. Now about damage control surgery, indications are hypothermia, that is temperature less than 35 degrees Celsius, acidosis, coagulopathy, that is normomechanical bleeding, prolonged PT, thrombocytopenia, hypofibrinomia, and the need of massive transfusion, that is the need of more than 10 units of the red cells or need for the body fluid replacement, prolonged time for definitive surgery, that is more than 90 minutes, and hemodynamic instability. Complex injury associated with the loss of physiological reserve, high energy blunt trauma, high energy high-energy blunt trauma, multiple penetrating injuries, visceral injury combined with the major vascular trauma, and injuries passing through the body cavity like closed head trauma, major vascular injury, and the pelvic trauma. Other conditions in the trauma patient, that is, injuries are better treated by non-surgical means, such as hepatic and the pelvic injury, corrected with the angiographic immobilization. Variation in the physiological reserve, that is, elderly, those with large number of comorbidity and athlete. Now, stages of damage control surgery. Stage 1 is rapid and the primary surgery. So, rapid surgery is applied with the purpose of control of bleeding and contamination. With the purpose of controlling bleeding, hemostasis, packing, clamping, ligation, and shunt procedure are performed. Then the stage 2 is the resuscitation. Following primary surgery, patients are taken into intensive care unit for the period of 24 to 48 hours for enabling aggressive resuscitation and patient monitoring. The main objective here is the elimination of the problem caused by acidosis, coagulopathy, and hypothermia triangle. First, it is planned for patient to be brought close to the euvolemic state to ensure end organ perfusion. For this purpose, patient is given blood products such as erythrocyte and the fresh frozen plasma. The shock of the patient get tried to be ameliorated with the fluid resuscitation. Following these techniques such as arterial catheterization and the pulse artery catheterization are applied. The hypothermia condition of the patient is important because the hypothermia can cause acidosis and coagulopathy to deepen. The control of hypothermia begin with the quick termination of initial operation. The quick removal of the weight covers from the patient, raising of the room temperature in the operating room, the use of warm resuscitation fluid and ventilator air and the heat regulating cover may warm the patient up in initial surgery room. The patient should be exposed to heat for about 4 hours before being taken into intensive care unit. Pleural lavage can be applied to the patient whose body temperature does not rise despite the method applied. If body temperature continues to be low, continuous AV heating can be applied. Coagulopathy is the goal as a secondary object. For this purpose, blood product and the resuscitation are planned for the patient. In first 24-hour, replacement is applied to the patient according to the rule of 10. That is 10 unit of erythrocyte suspension, 10 unit of FFP and platelet. Replacement is continued until prothrombin time period is 15 seconds and platelet number is 1 lakh. If fibrinogen levels are low, cryoprecipitate can be applied every 4 hours. In life-threatening non-surgical hemorrhage, recombinant factor 7A can be applied. If sufficient resuscitation is ensured, patient is exposed to heat and oxygenation is ensured, and then oxidative respiration increases and the acidosis is corrected by itself. Then stage 3 is the definitive and the complementary surgery. Following 24 to 48 hours of resuscitation after primary surgery in the intensive care, definitive surgery is performed. So this is the algorithm of the management of the polytrauma. So first, we need to identify the critical physiological factor, that is hypothermia, acidosis, coagulopathy, and prolonged time for definitive surgery or hemodynamic instability and pre-existing hypoperfusion. Then complex injury associated with the loss of physiological reserve, that is high energy blunt trauma, multiple penetrating injuries, visceral injury combined with the major vascular trauma, injuries passing through the body cavities. Then other condition in the trauma patient, that is injury that are better treated by non-surgical means such as hepatic and the pelvic injury corrected with the angiographic immobilization, variation in the physiological reserve, that is the elderly, those with large number of comorbidity and athlete. Then stage 1 includes primary emergency surgery, that is hemostatic and the prevention of contamination, drainage of septic contamination, temporary abdominal closure. Then intensive care unit management, that is resuscitation, the correction of hypotension, hypoperfusion, the correcting hypothermia, acidosis, coagulopathy. This resuscitation phase will last for 24 to 48 hours, followed by definitive surgery. Thank you, guys.